We'll give everybody couple minutes, 3 minutes to get out of their sessions and join the training. All right, we'll give folks just one more minute. Okay, good afternoon, everybody. Karen, do you wanna start with a little intro?
Of course, thank you. So we, at the end of, well, toward the end of the presentation, about 2:45, I will post the link for the evaluation. This program has been approved for MBCC and WBCEs. And I believe, please correct me if I'm wrong, but the psychology actually also does apply because they are accredited and aligned with the APA. So psychologists are also able to do that. That will be posted toward the end. The evaluation, once you fill out the evaluation within a couple days after the evaluations come in, I will send out a link via email so that you can apply for your CEs. On that CE form, remember you just need to select whether or not you're looking for MBCC or ASWB. Also, you can add your license number. At points, the link doesn't work for some people. Sometimes you need to clear your cache. Other times, if you copy and paste the link into a browser, it does work. So also during this presentation, if you have questions, please put them in the chat. We're going to try to get through the actual presentation and have a Q&A session toward the end. And then we will read the questions from the chat during that time. All set. Take it away, Ash.
Okay, thank you, Karen. Well, hi, everybody. Today's topic is risk management in outpatient settings, which is, of course, the setting for all TCN offices. And this is going to focus somewhat on a little bit on assessment, but it's going to really hone in on what do we do once assessment is complete and we see the potential of risk. Just a quick introduction for myself. My name is Dr. Ash Bowie. I'm the clinic director at the Wexford office of New Directions Mental Health, just north of Pittsburgh. I've been here for about 3.5 years, in practice for about 25. I have no financial interest to disclose. And here's our agenda for today. So we're going to be discussing both suicidality and the potential for physical aggression in our clients, looking at risk factors, protective factors, safety planning, legal and ethical obligations, and safety strategies. These are our main learning objectives. So by the end of the presentation, this is what your little quiz will be about. You should all be able to identify critical risk factors, warning signs for suicide and potential violence. We want to be able to develop an effective safety plan or at least get an outline of how to create one, including means restriction and the coordination with external supports. Should be able to understand and apply the legal and ethical standards related to TARSOF and the duty to warn, and the importance of documenting risk management interventions in a manner that supports both client care and legal protection for your clients and yourself. I don't think I need to remind anybody here of the critical importance of suicidality. I believe this number came from 2022, 2023, I can't remember which year, but around 800,000 people die by suicide globally each year, which is a shocking number. And beyond that, about 20 times that get involved in either an attempt or engage in non-suicidal self-harm. So we are looking at a very significant portion of the population that is at risk. Now, the challenge, of course, is that even though we look at these numbers and we know that there's a shocking number of people who could potentially attempt suicide, it remains very difficult to accurately predict who's most likely to attempt. The most we can do is to assess likelihood based on risk factors. We don't have a crystal ball. We can't say, well, if you answer questions in this way, or if you have these many risk factors, your likelihood is 95%. We simply don't have that kind of predictive ability. All we can do is know that certain factors increase the risk, others will reduce the risk, such as protective factors. However, no single risk factor or even cluster of factors guarantees an attempt or can, justify us saying, an attempt will certainly occur beyond a client telling you it's going to happen. And even then, it's not absolute. Many people with risk factors never attempt suicide, while some with few or what seem like low risk factors may actually attempt and complete. So we have to take all of that into consideration. We hold risk gently and flexibly based on what your client is bringing into the room. One way of looking at it is that risk factors can be static and dynamic. So an example of static risk factors would be like their history of attempts, their family history, chronic illnesses. These are things that are steady state, they're not going to change. Dynamic is current mood. What's their current access to potentially lethal means? What are any acute stressors happening in their life right now? Or substance use. While static can be informative and can help with our predictive efforts, dynamic factors tend to be more clinically actionable because these are the things that we can change. The goal is to reduce risk, not to predict with any kind of certain accuracy. That's an obligation nobody can carry. So there's a long list of risk factors, and most of you are going to be familiar with the majority, if not all of these. We know one of the most predictive risk factors is past attempts, especially when there are multiple past attempts, especially when there are recent past attempts versus one, say, 15 years ago or 20 years ago. Frequent high intensity ideation can be predictive. We need to be careful when our client is endorsing that. That's opposed to sort of more low level, what we call passive ideation, which is a risk factor, but it's not as much as having that high intensity ideation. When there's beliefs of hopelessness or feelings of hopelessness or being an intolerable burden to others, those need to be taken very seriously. Sense of being trapped or helpless, which can happen with severe mental illness or physical injuries or diseases of some kind. Chronic mental illness, especially when there is psychosis with command hallucinations. And by the time we get to that, a lot of those folks are going to be moving to a higher level of care ideally, but it's still something to look out for. When there's poor effective self-regulation, naturally, right? If somebody is potentially manic or impulsive, they may act on something that hadn't even been planned. We want to look out for significant shame and guilt, which is, of course, not rare amongst our clinical population, but when it's significantly sharp, we want to look for that. A profound loss, as frequently a recent profound loss, death of a loved one, or a serious romantic breakup can become risk factors. We want to look out for clients who have very low levels of social cohesion, meaning there's just not much in the way of friends or family around them. Naturally, when they voice a strong intent, we want to take that very seriously. Regular self-harming behaviors, even if they are not lethal, are a risk factor. So cutting, asphyxiation, behaviors that in and themselves may or may not be particularly lethal, but are indicative of somebody whose internal prohibitions against self-harm are less than where we want them to be. Specific plan with access to high lethality means is, of course, very dangerous. We always look out for when they're making plans, right? When they're giving away personal belongings, when they're writing sort of letters of goodbye to people. Then, red flags are really going off. Background conditions such as domestic abuse is a significant flag. For men, one of the highest predictors is major financial stress. DNA use can be a serious predictor. Presence of chronic pain, disfigurement, suicide in a first-degree relative, mother, father, brother, sister, can be predictive. And previous attempts to avoid discovery is also indicative. So this is just like, these are the main factors. These are the main things that we're looking for that indicate risk and justify follow-up with a use of the Columbia Suicide Severity Rating Scale, the Columbia, which is invalent. So everybody should feel free to learn how to use that and to use that on any patient that you feel might be of risk. So there's a couple of issues that I like to bring up here because this is not as well known. So for an example, when someone moves from severe to moderate depression, this can actually increase their risk for a period of time. The idea being that when they are in a very deep level of depression, their motivation is low, their energy is low, they're staying in bed all day. There's just not much energy to act. When they begin to recover, they can begin to have more energy, more motivation, more sense of agency. They can begin to act. But if there's still feelings of hopelessness, extreme guilt, or extreme stress, now they might have the energy to act on that. So it can be very positive to see a severely depressed patient begin to recover. We want to see that, but keep in mind that their risk can actually go up during this window of time. So we always want to keep a sharp eye out on that. Another element that we want to talk about just very briefly is how we assess some of these issues prior to doing the Columbia, right? So if somebody isn't coming out and simply telling you, right, I'm suicidal, but you think maybe there isn't, maybe there's, we want to make sure they don't have access, or we want at least to be aware of access to lethal means. We want to be able to talk about it, right? We need to be able to ask those questions. So as uncomfortable as it can be, we need to learn how to ask straightforward questions like, do you have any firearms in your home? Do you have access to lethal weapons in your home? How are they stored, right? Like, who has access to them? If you have a firearm, is ammunition stored elsewhere, apart from the weapon? You're going to want to talk about these things, but not through the lens of ownership. Many people who own firearms feel very strongly about their right to own, and that's not the debate we want to have. What we want to do is talk about it through the lens of safety. We want to reframe any such conversation as one of problem solving, right? Having access to firearms is easily one of the most dangerous elements when somebody is potentially feeling suicidal. And so simply looking at it through a collaborative, so what are we going to do about this? How can we increase your safety is the conversation to have. It's the same thing with cutting or non-suicidal self-harm. These can be uncomfortable questions to ask, but it's critical that we learn to grow comfortable with asking them in a very straightforward way, not in sort of a roundabout way, beating around the bush. We want to be straightforward and ask it very clearly so that we can get straightforward answers. Now, of course, on the flip side is we have the protective factors, which we want to identify when they exist and to build protective factors if they're absent or particularly weak. Right? Now, protective factors are not guarantees, we all know that, but the more and stronger they are, the safer our clients will be. The number one that we want to do, besides protecting them from lethal means, especially when they have access to firearms, is building and leveraging their social connections, right? Which can be family, it can be friends, it can be a local community, it can be a religious community, it can be a hobby community. Whichever it is, leaning heavily into that is probably one of the strongest protective factors that we can help our clients build. Initially, we want to directly address any issues of hopelessness, helplessness, and feelings of emotional lack of control, right? So we want to build hope. We want to build their sense of agency, competency, their ability to take control over their lives, and to build emotional resiliency. We want to do that throughout treatment, but at the beginning, that's where we want to focus. Building that list of meaningful reasons for living is key, which can be children, it can be pets, it can be unfinished goals in their life, it can be spiritual values, it can be commitments to others, right? Engagement in meaningful activities, it can be hobbies, service roles, anything along those lines. Each of those can act as a protective factor that we want to strengthen and build up. So community cultural involvement is key. For clients who are sort of spiritually oriented or religious oriented, we want them to lean into those activities and those spiritual communities. And of course, we want to help them develop those optimistic future plans to build this idea of what a positive future might be for them, in conjunction with building the idea that they can help bring that future to be, right? They have the competencies in the agency to actually affect positive change in their life. So once we've gone through sort of the process of assessment, right? We've identified the risk factors. We've identified the protective factors. We have a plan now to build on those protective factors. Very, very early on in this process, we want to build a plan, right? So we want that crisis planning. I advise all of you not to utilize suicide contracts. There's no evidence or that they work. There's no evidence that they decrease risk, and they can sort of hide or mask intention, but it doesn't reduce intention. So my best advice is to avoid these. A safety plan is far more effective, and I'll talk about CAMs here in a second. So here are the elements of a safety plan with somebody who is potentially suicidal. Right? We've talked about this before, but I'm repeating it because of how important it is. We want to remove lethal means or reduce or restrict access to them. That is probably one of the key ways that we can help keep our patients safe. Now, we do that in part, when possible, in coordination with family members or significant others, people in their lives, right? Especially in the household, right? Now, that's not always possible. Sometimes members of the household, like let's say it's a parent or an abusive spouse, it could actually be the source of stress that's leading to the suicidal thoughts, or at least is exacerbating it. So we can't always depend on family members or people in their immediate household to help. But in cases where we can identify them, we want to bring them into the safety planning. Okay. Part of it is identifying triggers to suicidal thoughts and intentions. So it's not enough just to identify their mood. It's not enough to identify sort of the conditions under which they are feeling helpless or feeling despondent. We want to get into the exact experiences and thoughts that can trigger an intentional thought, right? Or an intentional conception. Obviously, we want to develop coping skills in response to those triggers. So we can look to DBT, the skills of DBT being an excellent catalog of coping skills and regulation skills. We want to help them to identify the appropriate times to contact various people for different kinds of support. And that can range from calling a friend, calling a family member, to reaching out to mental health services. Like here in Allegheny County, in Pittsburgh, that would be a group called Resolve, right? So different places can have their own sort of emergency services outside of just 911. And 911 being sort of the final call you might want to make in the case of a genuine crisis. And so along those lines, you want to have a list of all the different resources and emergency numbers so that they're all easy to hand, so they have a copy and you have a copy. This is one specific thing that I want to mention because there's research that shows that it's quite effective. It's called caring contacts. And this is something that I encourage everybody with a potentially suicidal client to engage with, especially if you get one that's a step down from inpatient to outpatient, right? Or maybe partial hospitalization to outpatient, right? And this is fairly simple. All it really is identifying a group of people. You can't have too many. Friends, family, anybody in their community who knows them, to reach out every now and then, not 5 times a day, but over the course of several days and weeks, texts, emails, Instagram messages, DMs, postcards, letters, whatever works for them, to just reach out to check in, right? To give a thought, to give a note of encouragement, right? To remind them of a shared positive memory. research shows that this is a really effective element to include into safety plans for your potentially suicidal patients. So quickly, I wanted to go over the collaborative assessment and management of suicidal model, and I'm going to put that in the text because this is a very well-researched model that is very effective after suicidality has been assessed. Called CAMS. It's a framework for both evaluating and addressing suicide risk. It's very flexible. It can be easily integrated with other interventions and treatment modalities. It was made to be primarily used in outpatient settings, so it's not a inpatient tool for the most part. It has two main components. The first is the co-authorship of the plan with the patient, right? They need to be an active participant in this through the lens of an empathic therapeutic relationship. And it focuses on the function of suicide, right? So it tries to help the client identify what problem suicide solves, right? And this perspective has been found to be very effective because once you identify what the problem is that suicide can solve, then it's possible to start identifying other more adaptive solutions. So we don't have CAMS in Valent because it's not really like an assessment tool. It's more of a system. However, it is free to use. And all you got to do is plug it into Google and you can find a copy of it. And I encourage everybody with a potentially suicidal patient to utilize it. There are specific telehealth considerations. Naturally, the absence of physical presence complicates crisis intervention. You're not there. And they can very easily simply close the laptop or turn off the phone, and now you're out of contact with them. It can be a little more difficult to assess nonverbal cues over a screen, as we're all aware. The environmental context, you're not sure what's going on around them. Sorry, got a bug. And it can be a little more difficult to know the jurisdictional issues. So you're not sure, like, maybe what all the crisis numbers are in their particular neighborhood. So these are all things that have to be overcome. In each session, we want to know where our clients are. We want to have already a list of emergency contacts, right? We want to get that as soon as possible. We want a telehealth specific safety plan, right? Knowing where their crisis services are, where their nearby hospitals are. We want a backup communication plan. So if the video goes down, we can call. We want to know what plan B is. We want to have clear protocols for emergency escalation. So we want to know what those triggers are, what escalation looks like, so that you can know along each way what needs to happen. At the same time, we want to monitor for signs of emotional disengagement from our clients, right? When they seem like they're pulling away from their work with us, but we don't feel that they're really processing their suicidality. That's a flag, and we need to take extra steps. So here are steps that are very important to take, right? During, from beginning to end of working with a potentially suicidal client, right? An extra bit of monitoring, right? We want an extra eye on them, reach out to them maybe a little bit more often. And we have to do thorough documentation, right? This is where we don't want to go vague or minimal, right? When we're working with suicidality, we want very clear and complete documentation. What was said, what's going on, what interventions were used, what's the plan in place. Make sure we get all of that down. Now, along the same lines, we want to try to get as many releases of information as we can for people who might be involved in their care. So, you know, a spouse, a family member, a parent. maybe other members of their care team outside of TCN, right? Get those ROIs as soon as possible so that we don't have to violate confidentiality. We need to be ready to refer, right? You always want to have a referral plan in place. So if the acuity goes up, you know where you're going to be referring them to, and ideally they will know, right? So then you can discuss with them when it's time to go to a nearby hospital or a DNA program or whatever kind of care they might be needing at the time. So you also want to make sure you're staying in contact with peers, consultation partners, or supervisors if you're not yet licensed, right? I cannot underscore how important it is that when working with a potentially suicidal client that you maintain consultation contact. You want to do timely follow-ups. You might increase the frequency of sessions. You might go to 2 a week for a period of time until they're a little more stable. And of course, it is critical that you monitor your own state of mind and get the self-care that you need, right? That you will do your patients no good if you are developing an acute response to the stress of dealing with your patient. So make sure you get self-care. Okay, now we're going to switch over to the potential for violence and physical aggression and our duty to warn. Like suicidality, the risk factors for violence are somewhat similar. You're going to look for a history, right, of violence and criminal behavior. And yes, I know that that's vague, but the research actually shows that just criminal behavior doesn't have to be violent criminal behavior. And this is especially true if that criminal behavior started while they were young. This is highly predictive of the potential for violence. Substance abuse, impaired judgment or neurological impairment, especially when there's impulsivity or mania. Command hallucinations, paranoid delusions, these are risk factors, not necessarily in and of themselves, but when we start combining these things. Employment problems exacerbate potential anger problems, access to weapons, just like in suicidality. So in cases where we're looking at you believe there might be a potential for violence, we ask the same questions about firearms and access to weapons. We want to look at significant anger and hostility, right? And that's often sort of the first flag, right? They're presenting as angry, they're presenting as hostile, they're using language that indicates a desire to harm others or for others to be harmed, right? And when it's combined with a very acute personality disorders, cluster B disorders, borderline antisocial, when they start talking about developing specific plans, right? When you know they have access to a potential victim as opposed to, some superstar in Europe, right? If it's somebody that's accessible to them. All of these things begin to build the case for risk. Now, I wish we had a measure for potential violence in Valent, but we don't. You will note down at the bottom of this slide that there is a measure, the HCR20, and you can just plug in that URL and get access to that assessment tool. It's free. This is a series of screening questions to answer. So if you download this slide deck, you can have access to these questions. These can help to specify the specific types of violence risk with a client, right? So I'm not going to go through all of these, but like, what makes you mad? What do you do when you get mad? How would you describe your temper? What do you do when you lose your temper, right? Have you ever used a weapon in a fight? Have you ever hurt anybody? If there is past violence, then you can ask what happened, right? Who are the targets? What led up to it, right? One of the things you definitely want to look for is when they begin to justify their violence. So quickly, let's talk about Tarasoff. Now, this stemmed from a real patient, Tatiana Tarasoff, who was murdered all the way back in 1969 by a client who revealed his intention to harm her to a psychologist. Now, at the time, the psychologist did the right thing and contacted the police. However, neither the psychologist nor the police warned the Tarasoff family, resulting in her murder. This went to court and it resulted in Tarasoff versus Regents of the University of California. And it is now what we refer to as Tarasoff, which produced the duty to protect or the duty to warn. Now, the important thing to know here is that Tarasoff specifically only applies to California. It's California law. But every state has its version of it. And in the last session that we had, multiple people were giving examples of how things are different in different states. So it's very important for you to know what your state laws are regarding your duty to warn. Now, I'm putting some of the items from Pennsylvania, because that's what I know, being in Pennsylvania. So an example is clinicians must warn an intended victim and law enforcement when a patient expresses, and this is the language of the law, a specific and immediate threat of serious bodily harm. Not every state uses language like that. That's how it is. That's the threshold here in PA for us to violate confidentiality and actually make contact with somebody. In PA, it's enough that the target is identifiable. They don't have to have a name. That's actually a new law. It didn't used to be that way. If they didn't have a name, if you didn't know exactly who they were, you couldn't warn them. But now you can. So saying my neighbor is enough. My roommate is enough. My coworker is enough. If there are multiple victims, right, or potential victims, alerting law enforcement is sufficient. We are not expected to contact 15 people or 10 people. Notifying individual victims is possible. You're allowed to do so, but it's now optional. The duty is now over after you've made the contact to the police. If the potential victim is associated with an educational institution, again, this is a PA thing, like a school or university, we must also, in addition to those things, make a report to the Safe to Say program. So that's law. We're mandated to do that. And a threat against a vague or unnamed group is inadequate. That does not reach the bar, does not reach the threshold. Now, other states are different. The slides will be available to download after the training. So everybody take some time and learn the Tarasoff laws in your state. So just like with suicidality, there are protective factors as well. No surprise, a supportive social network, right? Relationships, strong relationships act as protective factors. The therapeutic alliance with the clinician has been shown through research to be a protective factor against violence. We want to make sure that they are doing their best to comply with their medication regimen. There's only so much we can do about that, but we want to reinforce the importance of that. Having insight into whatever their mental health concerns are is itself also a protective factor. Even there's a bit of a challenge because sometimes we have patients who don't want to hear what you have to say. But that insight is an important protective factor. We want to help them identify what's actually going on with them. So we want to develop that insight and build motivation to avoid harm. So they can sometimes begin to justify violence, right? That there's a benefit, just like there can be a benefit to suicide in the mind. of a patient, right? That's the assumption of CAMS. There can also be, right, there's a solution here to some problem that I have, and that's violence. We want to be able to identify, well, how can we solve this problem without being violent, right? So looking at it through a problem-solving lens. Now, there are many different potential treatments, depending, on the specific presentation of your patient. In general, though, drug and alcohol recovery programs can be effective if that situation is in play. Psychotropic medication can help, especially if they're manic or impulsive or have command hallucinations. DBT has a whole catalog of effective self-regulation tools, of course, and anger management training if their overall affect is angry. Now, safety is, of course, critical, both for your patient and for you, right? So you need to keep yourself safe. There's nothing about this job that requires you to put yourself in harm's way, right? So if you have any reason to believe that there is a potential for violence in therapy space, you need to account for that and plan for it as best you can, right? That includes reinforcing the therapeutic alliance. You want to position yourself near an exit with no obstacles, but also making it so that your patient can leave as well. That can be tricky in smaller offices. You want to avoid being cornered. You want to keep dangerous items out of reach. This is an important one. You want to be able to clearly communicate your behavioral expectations and limits in the office, right? So it's one thing for them to express difficult or uncomfortable or angry feelings, and another thing for them to begin to act on it in the room. It's clinically appropriate, and it enhances safety for you to clearly articulate what your limits are in the space. Try not to schedule sessions when nobody else is in the office. We want to make sure we have staff nearby, informed if necessary. Hope it doesn't come to that, but if it does, don't hesitate to let coworkers know that there's a non-zero chance you might be calling out for help. If you feel unsafe, you likely are unsafe, right? So you want to trust those feelings. It's okay to end a session early if you need to. And no matter what happens, make sure you document things clearly. And as always, discharge and refer out if it starts to spiral out of your scope of practice. Now, part of working with really doing any clinical work is the ability to de-escalate our clients when they are escalated, right? Number one is de-escalating yourself and knowing how to keep yourself calm when you're beginning to feel activated by an angry or upset client. So learning how to regulate your own breathing, right? Releasing as much tension as you can using whatever tools available to you. This is something that as therapists we should always practice. We should be always prepared to deal with a high stress situation. When we believe that escalation is occurring, we want to begin speaking very clearly using simple, non-confrontational language. We want to validate their emotions, even if we can't agree to demands, right? It's one thing to say, I can't do that, but I understand why you're asking. Avoid direct eye contact. If it's something that escalates tension, you want to judge that in the moment. You want to give your client a sense of control to the degree that is safe and possible. Avoid ultimatums. Use collaborative language. What are we going to do about this? How can we stay safe? What can we do to make this work? What can we do to calm down? Right? We can shift attention away from the trigger and towards self-regulation, right? And if the client is receptive, we can offer those stress reduction techniques in the moment. So we have a few other steps. These are quite similar to the ones prior, right? We want to explain our limits of confidentiality. I mean, I know we tend to do that in the very beginning, but if it's something that crops up later, we want to remind them of our limitations to confidentiality and the situations that might require an exception to confidentiality, right? And why, right? Because it's our job to help protect people and keep people safe. Get those ROIs, same thing with suicidality. If you can get ROIs for family members or outside care providers, get those, right? It's better to have those in place and in the chart. You want to be ready to make referrals if necessary. That's not something you want to do last minute, right? You want to have that in place, right? It could be a psychiatric evaluation, inpatient treatment, right? DNA recovery program. You don't want to have that discussion and be like, I don't know, right? It's better to have those in place and at hand. Please, please consult with others when you believe that this situation is in hand. I understand many of you are experienced, right? You know what you're doing. It's not about knowing what you're doing or not what you're doing. It's just getting that consultation to help you stay clear in your mind, right? To bounce ideas off of, to get a second opinion about how you're approaching things, maybe get an idea that you hadn't thought of. Consultation is critically important when we're looking at the potential of harm. As always, take careful and very detailed notes when we're looking at potential violence. We can increase frequency of sessions. And as with suicidality, we want to really engage in that self-care. So our final thoughts, right? I'm just going to say it again because I really want you to understand how important this is. Access consultation, get consultation, right? Or supervision if you're not yet licensed, right? Don't feel like it's reflecting badly on you. It reflects well on you to seek out consultation. You can do it with a peer. You can do it with somebody you know who's had a client like this before. You can reach out to your clinic director, right? Or your regional clinic director. It's like, get that consultation. It's also critical that you know your own limits, right? Know when a situation with a client has spiraled outside of your scope of practice, right? If it's outside your scope, you have got to refer out. You can do that in consultation so you can have the smoothest, cleanest possible refer out. Prioritize your safety, please. Again, nothing about our job requires you to be placed in harm's way. Trust your instincts. If your gut is telling you that something's wrong, trust that feeling. And finally, as always, care for yourself, right? High risk cases come with a lot of stress. We can feel a lot of obligation, a lot of worry. We feel like now it's our job to take care of these people and keep them safe. That comes with a heavy burden sometimes, right? Schedule that recovery time, right? Make sure you're getting peer support, therapeutic support if you need it. Maintain your own wellness. It's critical. And here's a list of references for the material in this training. And that's it for today. We can now open it up to Q&A.
Dr. Rash, can you talk a little bit about our Medicaid, Medicare clients who typically will go through our intake teams who are often not trained to assess for need?
Mm-hmm.
So one of the questions is if intake is bringing on a high need client, right? And I'm seeing this, let's say they put the client on my calendar in a week, and then I finally see the client and I'm like, no, this client needs a higher level of care, because what I find through the intake is they're homeless, they're house couching or couch surfing, they're in a relationship, but they're in a relationship to get needs met. And so the relationship is domestic violence. And so what happens is I'm presented with a spiral to take, my time and energy, right? Because it's this between my time and energy and being a fee-for-service clinician. I think that's one of the challenges. as we are taking on higher level, higher need acute clients
Yeah.
Within the organization. And so
Right.
not, and keeping in mind the importance of staying in one's lane versus case management or crisis management. So the focus.
Yes.
Does that make sense?
Yes. No, absolutely, because it can happen, right? Sometimes patients going through the intake process can just sort of slip by without revealing these underlying issues. And when that happens, we can be pulled into more of a social work role. But we're not social workers at TCN. That's not our role. And uh, they can be bringing with them symptoms or conditions that are way outside the scope of even just a generalist outpatient clinic. Like floridly psychotic, or they're primarily dealing with homelessness or drug abuse. And that's the top line issue. Yes, there may be depression. Yes, there's anxiety. Yes, there's bipolar or OCD. But none of that can be addressed until like these other issues, right, are under control.
And I'm sorry. Maybe I'm going like a couple steps beforehand of like,
Mhm.
if, as we are not crisis or crisis services or case
Right.
management, with the intake team having a structural plan to be able to field out, because if it is, I'm crying out for help and I can't be seen with a provider for a week, and then I go and do the assessment and then been like, I'm sorry, I need to refer you out due to X, Y, and Z.
Mhm.
It causes disruption, dysregulation for the client, because I waited to see you for a week. Why couldn't they tell me? Why couldn't they tell me this when I
Uh-huh.
filled out my web form?
Uh-huh.
And so that they provided me with an alternative route to services, get well, and then or get better and be able to support before you come in to see me.
Yeah, well, and I know that at least in my region, the PA, I believe West Virginia region, uh, uh, I know that Central Intake has been developing a more robust question tree to try to suss out some of these more acute issues. I think that's going to be a project in process, because they're not clinicians, right? They're gathering information. They're not qualified, and it's not the right circumstance by which to assess somebody over the phone to say, "Oh, this is what you need," unless it is quite obvious that they're in crisis and they need to be referred to a crisis unit. Um, so I am hoping that over time that tool will become more sophisticated and capture some of those sort of high acuity clients that slip through. But when they do slip through, uh, the thing to do immediately is to go and talk with your clinic director, right? And to come up with a plan to find out, like, is this somebody that could be seen within our clinic? Maybe there's somebody who's comfortable working with this patient, or is this something that's truly outside the scope of a TCN outpatient clinic and we need to refer out? Thanks. It's a good question, Michael.
Thank you.
I think we have time for another quick question or two. Abigail?
I was just wondering if you have any specific recommendations for working with minors. I work with a lot of kids, especially those who have begun self-harming, and when constructing a safety plan, really encouraging identifying specifically adults who they can reach out to, with some of them having some difficulty with that. So with the whole caring contacts, I was wondering if sticking to that adult or encouraging maybe a more emotionally mature peer, but just wanted to see your thoughts.
Yeah, it works. It works with kids as well as adults. I mean, if we're talking, 8 years old, it's a little more difficult, because because then you're looking at more adults rather than peers. But by the time they start hitting into their tweens and teen years, you know, they can start identifying more mature peers that can do the caring contacts. Absolutely. Also, I have found that working with kids, and this is especially true when you start hitting the tweens, 11, 12, 13, that looking at the desire for self-harm through a functional lens, you don't want to use, you know, complex language, but through that clinical lens, like what problem is this solving? What are the pros and cons is a really effective approach. Now, every client's different, which is why you want to get consultation. But something to always consider is to look at self-harm through a pro and con lens. So often kids are just told that's horrible, it's bad, you shouldn't do it. Of course it is horrible, of course they shouldn't do it. But that also doesn't acknowledge that there's a problem they're trying to solve. And in their mind, they think this action will solve it. It's maladaptive, but the desire to solve their problem is legitimate. And that's something that we can provide for kids that maybe they're not going to get from a parent or a teacher or a counselor at school or anybody else who's just going to go all in on telling them, don't do it, don't do it, don't do it. Of course, we're going to say don't do it, but we might be the first ones to say, but we get why you're thinking this way. So validating that idea can be very powerful. Okay, well, I want to give everybody a passing period. As always, it's a privilege to present to all of you. I hope you found this useful, and I hope you're able to take this to your advantage for your clients. So take care, and thank you very much, everybody.
Thank you.
Thank you.
You're welcome.